मैंने कर दिया है लाइव ना, जस्ट लाइव हो रहा है अभी अपने। ओह सॉरी सॉरी, मैंने
Good afternoon, everyone. I think I have shared a pretest in WhatsApp also. Again, I'm going to share here also. By the time other people will join, you can do your pretest. Thank you.
Ôi, Mất ơi, bỏ.
Good afternoon. Good afternoon, everyone. Thanks for joining with us. So we will wait 5 more minutes for the participants to join. And again, I have shared a pretest link in the chat box. Please go through it. Thank you. Suresh sir, good afternoon. Suresh sir, am I audible?
Yes, good afternoon. Good afternoon, ma'am. Yes, you are audible. Yes, ma'am.
Thank
Thanks.
you. Thank you, sir. Sir, we will wait 5 more minutes, then we will start our today's session.
Yeah, all right. No issues.
Okay, sir. Thank you for joining
Thanks.
with us.
Yeah, thank you.
Suresh sir, Dr. Saurav. And then also I request all the participants, please, while doing the registrations, please put your correct name, because still some of the name I have getting like Galaxy, Oppo kind of things. So I request all the participants to join with your correct name, because we are counting your attendance as per your name. So thank you. And if possible, I request participant to switch on your video so that, we will have a like face-to-face kind of interactions. If your network is okay, then you can switch on. Otherwise, as per your visibility or as per your convenience, you can do so. Yes, I have seen like hand raise from one Oppo Plus. Yes, you can unmute yourself and you can ask, or either you can write in a chat box so that I can reach out to you. Yes, Teresa ma'am, I think I have seen your hand raise. You wanted to ask anything? You can unmute yourself and you can ask. We will start our sessions by 2:35. We have doing a live YouTube stream, but for this this is the for your reference in future use. But I suggest you to join through Zoom platform only, so that we can get your registrations detail. Yes, Teresa ma'am, I've seen your hand raise. You wanted to ask anything? We're waiting for one more button. Yeah. So now we are already 2:35. So we will start our today's session. Good afternoon, everyone. Once again, welcome you all in our 1-month certificate course of PICU training. So without much delay, we would like to continue with our agenda, today's agenda. So I just wanted to welcome our sir, Dr. Suresh sir. Dr. Suresh Kumari Anguri sir is a qualified MD DNP in pediatric critical care, and presently sir is designated as an assistant professor in the department division of pediatric critical care in PGIM Chandigarh Hospital. Area of interest is sir is interested in mechanical ventilations, point of care ultrasonography, HLH in PICU, and got microbiome and probiotic in PICU. Sir has done a publications more than 150 in a national as well as international journal, and also sir have received so many award and achievement like Major General Mutual Gold Medal in 2012, Best Paper and Best Poster Award in 2019, and also Professor D. Subramaniam Gold Medal in 2008, and also Dr. H.B. Dingley ICMR Award in 2019. So welcome you, sir. Hello, am I audible? Yes. Okay, yes, sir. Sir, welcome you once again on behalf of NIGRIMS as well as all the participants who have joined from different district of Northeast State Hospital. So thank you for joining with us, sir. So now we will proceed with our first presentations. Today we have two presentations. One is in management of ARDS, and second we have ventilator titrating problems and all. So first presenter is Dr. Rosina ma'am. Ma'am is doing a management of ARDS. So without much delay, I would like to request Rosina ma'am to proceed with our presentation. Thank you so much. Is my slide visible? It's visible, no? Okay. Where do I go to slide? Okay. Good afternoon, everyone. Today we will come to management of ARDS. I'm sure you have been seeing this word time and again, especially with the COVID pandemic. All your guidelines says you need to manage. You need to know how to manage ARDS. Okay, so before we start with the management of ARDS, we'll run a small poll just to have a baseline idea of how many of our participants have been involved in the management of a case of ARDS. Can we run the poll, Nanuka? And I also like to welcome Dr. Suresh Ankurana, sir. Thank you so much for being with us today. And hopefully in this topic, we would try and with your presence, we'll try and clear our doubts and will benefit our participant with your presence. So thank you so much for being with us today.
Thank you, ma'am. Thanks.
We have I think we can end the poll. Okay. So we can share the results also. End the poll. So from the poll, as you can see that we have, I think we have a fairly good number of participants today who have managed ARDS. This is a very, very good response. So a lot of terminology that I'll be using, a lot of a few scenarios I'll be saying, I think all of you will be familiar with, and the rest we will go slowly. If there are any doubts, if you have any questions, please put them in the chat box. We will take all of them at the end of the session. So we can stop this now. The results has been shared, right? Okay, let's stop this. Okay, so when you talk about when we talk about ARDS, what we'll do is first let's
let's define what ARDS is. Then we'll come to the causes of ARDS, and we'll talk a few briefly about the stages of ARDS, and again some normal physiology, lung volume and lung compliances. What happened to the lung compliances in ARDS, and finally we'll come to the management of ARDS. Okay, so in definition of ARDS, these are the 4 things that you need to know. Okay, so this definition was taken from the American European Consensus Conference in 1994. This was modified in 2012 in Berlin. So any condition that is acute in onset, and acute means onset within 7 days, that also has a bilateral pulmonary infiltrates on your chest X-ray, accompanied with severe arterial hypoxemia. Okay, so this will be evident from your arterial blood gas. So you look at the PF ratio, that is your partial pressure of oxygen is to FiO2. Okay, if that number is less than or equal to 200, that is your ARDS. If it's less than 300 or equal to 200, that is your acute lung injury. And then all these causes of respiratory distress, hypoxemia, and infiltrates, there is no cardiogenic cause. That means you've ruled out any left atrial hypertension. Now, this definition, in order to encompasses more cases of ARDS, okay, and also improve the outcome, what happened is in 2015, the Pediatric Acute Lung Injury Consensus Conferences, they uses another criteria, which is oxygenation index and oxygen saturation index instead of the PF ratio. They found that there are a lot more pediatric children who fit into the criteria of ARDS, and also hence the outcome also has improved. Okay, so let's talk again about what is oxygenation index and what is oxygen saturation index. Okay, so oxygenation index is you use this formula. It's the FiO2 into the mean alveolar pressure measured in centimeter of water into 100 divided by your PaO2. That is your partial pressure of oxygen. This number you will get from your ABG. Okay, this number you'll get from your machine. Then your oxygen saturation index, if you don't have an ABG, if you don't have a partial pressure of oxygen, what you can do is you get the same numerator, you divide it by your saturation. Okay, so based on these calculation, you can divide ARDS into mild, moderate, and severe. There's also a division based on your PF ratio as well. Okay, so in oxygen index, if it's between 4 and less than equal to 8, it is mild. Okay, and if it's between 8 and less than equal to 16, that is moderate. And if it's more than equal to 16, that means your ARDS is severe. This is for your oxygenation index. Now, if you're using your oxygen saturation index, if the number is between 5 and less than 7.5, that is mild. Between 7.5 and less than 12.4, that is moderate. And if it's more than equal to 12.3, that is severe. Okay, so I want you all to please note down this calculation, because the next slide will need to do some calculation, and I want to see your answers in the chat box. Okay, please, I'll stop. Maybe I'll pause for maybe for 4-5 seconds. Please write down this formula of oxygen index and oxygenation saturation index, because we will use this I'm taking an example from one of our cases, so we will interpret this in that case scenario. Okay, so let's go to the next slide. Okay, so we have this case. This is a 1-year-old. This is an infant who came with ARDS, and this was the ABG picture. Okay, so this child was getting an FiO2 of 60%, which is 0.6 for calculation, and the saturation was 90%, and the mean alveolar pressure was 20. Okay, so based on this ABG, please calculate the PF ratio for this patient. This is from this ABG, you can see that this is your partial pressure of oxygen. If whoever has calculated, please write down the answers. I'll wait for another maybe 10 seconds. If you want me to go back to the formula, I can go back as well. Okay, so your oxygenation and your PF ratio is just PaO2 by FiO2. Okay, so PaO2 is already here and FiO2 is here. All right. Okay, so all right, so let's look at this calculation. So your PF ratio is the PaO2, which is 18 here, okay, by your FiO2, which is 0.6. So this is come up to be 30. Okay, and your definition for ARDS was less than equal to 200. So this is again falling into your definition of ARDS. Okay, so let's use the same example to calculate the oxygenation index. So your formula for oxygenation index is FiO2 into mean alveolar pressure, is already written here. Okay, into 100 divided by your PaO2. Okay, so your oxygen index using that formula, so, okay, FiO2 0.6, your mean alveolar pressure is 20 into 100 divided by your PaO2, which is 66. Okay, again, this falls under your severe category. Then again, if you don't have an ABGA, you need to use this one. So this is, using that formula, we're getting a value of 13.3. Okay, I hope this is clear. Now, this is the same slide. So this patient we have falls under the category of severe ARDS. Okay, so by using this to either the PF ratio, OI or OSI index, you can categorize which ARDS this patient is having. Okay, so let's come to the next part of this talk, which is the causes. So there are various causes of ARDS. It can be direct causes or can be indirect causes. Okay, your most common causes, direct causes pneumonia. It could be your viral pneumonia. It could be a bacterial pneumonia, be atypical organism pneumonia. It can be because of aspiration pneumonia, because of other causes of aspiration. It can also be because of multiple transfusion of blood products. So these are the most common direct causes of ARDS. Then the other uncommon or rarer causes would be direct traumatic pulmonary contusion, drowning, inhalation injury, and reperfusion injury. Okay, so these are your direct causes. Then you have your indirect causes. These are again equally important because a lot of cases you might not have pneumonia or any direct trauma as your primary complaint. These would be in these boxes. So you'll have a couple of times you'll have children coming to you, presenting to you with sepsis, with shock or trauma elsewhere, trauma site elsewhere. They can also manifest or develop ARDS in that case. Always be mindful and watch out for your ARDS in these cases. These are your common other indirect causes. And then your we call rarer causes is exposure to cardiopulmonary bypass, case of acute pancreatitis, drug overdose, case of disseminated intravascular coagulation, or following burn injury. Then okay, so I need to hide this floating thing. Okay. Okay, so and then your last cause is your head injury. So these are your always be what we call on a watch out for ARDS, even in these indirect causes of indirect causes as well. Okay, so then let's come to the stages. There are basically 3 stages of ARDS: your exudative stage, your fibroproliferative phase, and your recovery phase. Okay, so in your exudative phase, this is again there'll be an acute development of respiratory distress, okay, followed by decreased pulmonary compliance, and there'll be an accompanying hypoxia, okay, or hypoxemia. The patient will also have tachypnea. There's increase in respiratory rate. When you do a chest X-ray, there'll be diffuse alveolar infiltrates. Okay, this will become clearer as we come to the next slide. Okay, then after this phase is over, you reach the next phase, which is a fibroproliferative phase. And once this stage is over, then most of the time the patient will go into recovery phase. Very few of them will have either residual fibrosis or other complications or reduced compliance in the lungs. Okay, so in order to make it clear, this diagram is if you look at this left. This is the picture of an alveolus. Okay, the one on the left is a normal, healthy-looking alveolus. Now, these are what happens when you breathe in air, your oxygen will enter through your upper respiratory tract, enter your lower respiratory tract, and finally, the gas exchange will happen at the alveolar. Okay, at the alveolus. Now, whatever oxygen you are taking will go in, and it will perfuse through this what you call type 1 cell through the interstitium and then reach the capillary. Okay, and then what will happen here? It will go and bind to your hemoglobin and then increase the oxygen capacity of the body and also correct your hypoxia or hypoxemia. Okay, so this is what happens in your normal alveolus. This is your type 1 cell. This is the one that is involved in your diffusion. The type 2 cells is the one that secretes the layer of surfactant that you have here. All right, and then you also have a few alveolar macrophages for the alveolar protection. Now, this again, something about surfactant is this surfactant, it helps to keep the alveolar open. Okay? It helps to maintain that tension and also helps to prevent it from collapsing, and therefore hence helps in oxygen diffusion to the capillaries. Now, what happened when you have an injury in the alveolus, in this alveolus? Okay, it could be because of your direct injury, like we've already listed before the causes, or it could be because of your indirect injury. Okay, so what happened is, what this injury to the lung will affect your type 1 cell, and also this whole surface, you lose this type 1 cell, that they'll be affected. Your surface, the layer of surfactant will also get affected. Now what happens, because of infection, there'll be increased permeability from the blood. There will be infiltration from the blood of neutrophils into the alveolar as well, into the alveolar space as well. Okay, and this will cause a series of systemic reaction and release inflammatory mediators like your interleukin-1, interleukin-6, interleukin-10, and other inflammatory mediators. Okay, now this will lead to that acute exudative phase. All right, so what will happen is, even if you are breathing, this oxygen will not be able to diffuse because your cell has been destroyed. Okay, this oxygen will not be able to diffuse and get into your capillary and enter your RBCs. All right, so what happened? This is what will cause your tissue hypoxia. All right, so the child will be breathing, but there'll be no oxygen that will be going into your capillaries. And also this is sorry about that. And also this will lead to your clinical manifestation like your tachypnea, your respiratory stress, and then your chest X-ray findings of alveolar infiltrates. Okay, so this is what is happening at the alveolar level. All right. Then having understood this, let's go a little bit further, a little revision to your lung volumes. I think this is one of the questions in the pre-test. So what happened is, this is your tidal volume. What it essentially means is the amount of air you're breathing in and you're breathing out quietly. Okay, that is your tidal volume. In adults, about 500 ml. Now, what happens is when you take a forceful inspiration, you're breathing in and suddenly you are forcefully inspiring. Okay, so that is what is called as your inspiratory reserve volume. And on the other hand, when you're forcefully exhaling out, that is your expiratory reserve volume. Okay, the combination of tidal volume and inspiratory reserve volume is your inspiratory capacity. A combination of this inspiratory capacity and expiratory reserve volume is your vital capacity. Okay. Now there is one volume of in the lung that's called the functional residual capacity. This is the amount of air that is present in your airway after a quiet tidal volume, quiet breathing in and breathing out. This functional residual capacity is important because it keeps your alveoli open. Okay, so this is having understood that, let's go to the first pole, Nanuka. Okay, so this is a pole that's not first pole, second pole, sorry. So the second pole. Okay, so if you have a balloon, which of these would be easier to blow or inflate? Is it a brand new balloon or a balloon that is partially blown open? We're getting lots of responses. Can we? I think we can end the poll now. I think we can end the poll now, no? End the poll and share the results. Okay, so as you can see from the results, okay, about 80%, which is your right. Okay, so a majority of you know that it is easier to open a balloon that is partially open, okay, instead of a brand new collapsed balloon. So this is what your FRC basically is. Okay, so it keeps your alveoli partially open, so you don't need that much pressure to keep it patent. Now, having understood that, let's go to what is known as lung compliance. Stop sharing results. Yeah. That's it again. let's go to the next component of our ARDS and understand what is lung compliance. Okay, lung compliance is basically a change in the volume over a change in pressure. What it basically means is, in order to achieve that tidal volume that we talked about, what is the change in pressure that is required to bring that tidal volume or that change in the volume? Okay, that will depend on your lung compliance. Okay, if your compliance is normal, what happens is you will require normal pressure to bring about that change in your volume or your tidal volume. All right, I have put two pictures here. So basically you have a child or a person trying to blow up a balloon or a car tire. So if you can just write in the chat box, which one do you think will have a good compliance, the balloon or the car tire? Which amongst this will require less pressure to cause an increase in the volume, to inflate it? Okay, some of you are saying balloon, some of you are saying tire. So basically, to open a balloon, you can blow it with your mouth, isn't it? But to open this tire, you'll need a higher pump, right? Or I don't know if maybe some of you have managed to open a car tire with your mouth and blow it. Anyway, so basically what I'm trying to say is, in order to inflate this big car tire, you need a higher pressure. Okay, that means the pressure, the compliance of this tire is poor. Okay, and the compliance of a balloon is good. I hope that makes it simple and there's no more confusion in that. Okay, so having understood what compliance is, let's come to what compliance is in your lung and in ARDS. Okay, so when you are, this is your this lower zone, this is your pressure volume curve. Okay, this lower line is your pressure during inhalation, and this one on top is your pressure during exhalation. Okay, so during inhalation, your pressure, and there's something called lower inflection point. So there's after a certain amount of pressure, a certain amount of pressure is required to bring about an increase in the volume. Okay, so this is a lower inflection point, and up to a certain amount here, you can see that there is something called beaking. Okay, so this is your upper inflection point. Now, what is the significance of this is, you need to ventilate your patient between this lower inflection point and upper inflection point. This is called a safe zone. If your pressures are below this, it will cause atelectasis. That means your alveoli will collapse. Okay, because of the direct injury and loss of surfactant, they will collapse. You need a higher pressure to keep it open multiple times. All right, and again, it will cause some trauma, which again we will come to that later. And if you keep it if you put your pressures too high, it will cause over distension again, which will again lead to lung injury. All right, so let's see what is this in respect to your ARDS. So this is the compliance of, this dotted one is a compliance of a normal lung, and this one with the solid line is a compliance of a lung in a patient with ARDS. So this is your lower inflation point, this is your upper inflation point, and this is your safe zone. All right, so if you compare at the amount of pressure required to bring about this volume, look at this preset volume here in this normal lung, the amount of pressure required is here, isn't it? I have not drawn a line, but if you, this is the low inflection point, the amount of pressure required to open this lung is less. All right, so the compliance of this lung is good. Whereas you look at the lung with ARDS, the amount to reach this volume here, the amount of pressure you need is very high. Okay, it's way above the normal requirement for a normal lung. And this is your zone, this is the pressure you need. So basically, this is where you will set your PEEP, and this is where you will like to keep your PIP, that is your peak inspiratory pressure. If you go above beyond this upper inflation point, you will cause over distension and again some lung injury. All right, I hope this will clarify your idea and your idea about lung compliance. Then having understood this basic thing, let's come to the proper management of ARDS. Okay, so these are the various strategies that you need to follow for managing any case of ARDS. The first one is control the causative factor, whatever it is, whether it's a direct injury or indirect injury, you identify that and appropriately take measures to control that. Then your mainstay of treatment is your mechanical ventilation. There has been some usage of non-conventional ventilation as well. Though in children, I think there's not been much studies to show whether this is superior to mechanical ventilation. Then you will have to continue on with your drug-based therapy based on your causative factor. You have to be very mindful of your fluid administration. And then you also, we've mentioned initially in our previous session, that prone ventilation has also been used as a part of your strategies for ARDS. And then your supportive therapy will continue. Then let's look at the first slide. Okay, so you have a child coming to you with respiratory distress. Okay, after you've ascertained what is the causative factor, direct or indirect causes, you do a quick assessment. Clinical assessment, you see the child is tachypneic, the child is hypoxic, you put the pulse oximetry, you get order a chest x-ray, look at the ABG. Okay, after doing all of this, you can confirm your diagnosis of acute lung injury or ARDS based on these, again, 4 criteria. Whether it's an acute onset, whether there's presence of severe hypoxemia, there's a bilateral pulmonary infiltrates based on your chest x-ray, and there should be no evidence of left atrial hypertension. Okay, so after you have identified the underlying risk factors, whether it's direct or indirect cause, then you come to your management. Again, your management, don't forget your stabilization. All right, it's a sepsis or pneumonia or shock, you can start appropriate antibiotics and continue with the rest of your supportive care, which again, I will talk about later. Then your acute, the mainstay in your management is your respiratory management. So with respiratory management, like I've said, you have an option of either non-conventional ventilation or conventional ventilation. In non-conventional ventilation, you can use high flow nasal cannula, you can use CPAP, BiPAP, NIV. Again, like I said, there's not been much evidence to show whether this is superior or whether survival is more in children. Okay, what we do know is conventional ventilation. All right, so you've seen this child, you have diagnosed, you can confirm the diagnosis of acute lung injury or ARDS. You have stabilized, you have pre-oxygenated, now you have done rapid sequence intubation, and you have intubated this child. Again, you've kept the child on conventional you've attached the child to a mechanical ventilator. Now coming to the modes, we are going to be concentrating mainly on SIMV mode. This is the mode. Again, whichever mode you're familiar with, you use that mode. This is PRVC. This is the pressure regulated volume control mode. This is a more advanced form of ventilation, mechanical ventilation. But for our session, for those who are just beginning or starting with ventilator, you can focus on SIMV mode. Okay, so you choose the mode, you go to SIMV mode, and then your initial ventilator setting. Okay, so initially you can start with an FiO2 100%. But do not keep it like that. Okay, once you have set it down, you try to, our aim is to keep it below 60%. Okay, then you set the rate. The rate again will depend on the age of the child. If it's a neonate, you set it at 30 to 40 beats per minute. If it's an infant and small children, between 20 to 30. If it's an older children, between 15 and 20. And once you've set you've adjusted your FiO2, your rates, then you look at your inspiratory time. Our aim is to achieve an IE ratio of 1:2 to 1:3. Okay, so IE ratio for infant, you can go as low as 0.3 to 0.4 second. For smaller children, from 0.5 to 0.6 second. And older children, 2.9 to 0.7 to 0.9 seconds. Now here is once you've set the rate and the TI inspiratory time, the IE ratio will automatically get calculated. Okay, then your PEEP, if you open up the pressure volume curve on your screen, ventilator screen, look at the lower inflection point, and then set it at 2 or 3 or 5 centimeters above the lower inflection point. Again, this is to prevent atelectasis and to ventilate in the safe zone of ventilation. Then next comes your control. Okay, whether you're using pressure control or volume control. In ARDS, we advise volume control if you're using a cuff tube. Okay, so your volume set it at less than 6 ml per kilo. If you're using an uncuffed tube or if you're using pressure control, you can set it as per the age. In neonates, you can set the pressure, your peak inspiratory pressure between 18 and 22 centimeters of water. And in children, we always advise to keep it less than 30 centimeters of water. Then after having set the ventilator, your job is not over. Okay, that is just the beginning. You need to see what is your target, what was the initial indication for your ventilation. Okay, you need to set a target endpoint so that your child had hypoxemia, wasn't it? Okay, your ABG, our child ABG PaO2 was only 18. So our aim was to increase our PaO2 to at least 60 to 80 millimeter of mercury. And then the child also had acidosis. The pH was 7.2. Our aim is to correct this acidosis. The pH should be between 7.3 to 7.45. That is one of our target endpoint. And the saturation was, in any case, saturation is 90% or less than that. Our aim is to keep it between 88 and 95%. Okay. And once you have reached a target endpoint, you need to monitor and then see what happens. You can, if the child can be stable, you can continue monitoring, keep reducing FiO2, and then you can plan for weaning and extubation. These portion, monitoring and weaning, we will discuss about it in our next sessions. Then let's come to this particular part. Okay, now what happened if your conventional ventilation fails? These are all your other advanced ventilation, which again is beyond the scope of this session and our target audience. But then it'll be good to know that you can, if your conventional ventilation fails, you've maximized your pressure, you maximize your PEEP, and you've not been able to meet your target endpoints, then you can try these. You can try prone positioning. If you have the facility for high frequency oscillation ventilation, you can. Here, the rest, they are not proven. There's no sort of proven benefits in ARDS. Moreover, they're very expensive and they're not easily available. Okay, so this is what other things that you can concentrate on if your conventional ventilation fails. Then again, there may be other reasons for failing, which we will talk about in the next lecture. So again, we'll go back and see why it has failed. Maybe something simple that you can correct and intervene. Then if your patient tolerates it well, there's no evidence of lung injury, you titrate your saturation to maintain an FiO2 of at least less than 60% or 50%. If again the patient is stable, you can wean as tolerated. Okay, but if the saturation is not maintaining, or it is maintaining at a very high FiO2 of more than 70%, or a very high mean alveolar pressure, okay, and there's repeated ventilator-induced lung injury like your pneumothorax, subcutaneous emphysema, and other lung injury, and the patient is not improving, then you can try other maneuvers like prone positioning. I've already said. Look at your fluid balance. Maybe try an adequate fluid balance. You can use furosemide infusion. All right, and then if available, like I've already said, you can try these maneuvers. And then if your condition improves, then you can switch back to conventional ventilation and consider weaning. Okay, and then remember your initial indication for putting the child on ventilation. If it is a respiratory cause like pneumonia or your COVID-19 ARDS, then you need to wait for the disease to evolve and then reach the resolution phase. So you need to give it some time. Okay, you are ventilating not to treat the disease, just to give some time to help ventilate the lungs, so that your initial disease will evolve and then resolve. Okay, that's why we are just buying time for this process, this inflammatory process to resolve, and then we can wean the patient and then extubate as if the condition improves. Then we have talked about ventilator lung injury, ventilator-induced lung injury. So these are complications of respiratory support. Okay, any intervention that we do are not without side effects. So you should know about this. Okay, so there's something called volume trauma, because in ARDS, we've already shown you in the graph, the lung has a very low compliance. Okay, so in order to achieve, if you're doing a volume controlled ventilation, in order to achieve a particular volume, what happens is you're going to give a very high pressure. Okay. So that can cause volume trauma. Why? Because when you look at your alveolar involvement, not all of them will be involved. Okay, some alveolar will be intact, some will be affected. Now, the volume that is going to the affected one will increase your oxygenation, but the one that are intact or not affected, those will be affected by this high volume or high pressure to achieve the target volume. Okay, so that is what will cause your volume trauma. Then athletic trauma is, again, if your PEEP is not adequate, okay, your alveolar is repeatedly collapsing and expanding. Now, what will happen is this will cause what is known as athletic trauma. Rheotrauma is because of the high gas flow. Again, this is more common in neonates when you're using high flow nasal cannula, higher flow. Biotrauma is because of the severe inflammatory response within the lung because of the disease itself, and oxygen toxicity, like we said, do not stay on a higher oxygen for a long time, because that itself, oxygen is also toxic to the lungs. Okay, so we need to be mindful of all these complications and ventilator-induced lung injury when you are using a ventilator. Then there's something called lung protective ventilation strategies in ARDS. Okay, this is basically to minimize your ventilator-induced lung injury, while at the same time maintaining adequate oxygenation and ventilation. Now, you remember, when we are ventilating, we don't need the perfect end targets. Okay, we don't want normal saturation, we don't want normal oxygen. We have to oxygenate in such a way that you avoid these ventilator-induced lung injury. Okay, enough to provide oxygenation and ventilation, but without causing any injury to the lungs. Okay, so what are these lung protective injury strategies? They advise the use of low tidal volume of less than 6 ml per kilo. Then your plateau pressure should not exceed 30 centimeter of water. Your mean alveolar pressure should not exceed 20 centimeter of water. You use your PEEP optimally by using your pressure volume curve. Avoid very high PEEP above 15. Try to keep the FiO2 between 0.5 and 0.6 or 50 and 60%. Use a cuff ET tube in inline suction. What happens when you have an open suction? Okay, every time you're removing like we said, in ARDS, a lot of exudates, isn't it? So they will also come out. With time, they will come out in your trachea, and that will cause tube block. So what happens is you need to suction them out. So we prefer that you use inline suction. Why? Because when you're doing inline suction, you don't lose your PEEP or the pressure that you have given to inflate the lung. Okay, so we advise an inline suction. And there's something called permissive hypercapnia is also is also allowed to prevent your ventilator-induced lung injury. Okay, so what is permissive hypercapnia? These are strategies to reduce barotrauma and ventilator-induced lung injury. We tolerate a higher PCO2 to limit your peak inspiratory pressure. Okay, so in order to avoid high pressure used to achieve a target volume, okay, we accept a higher PCO2, maybe up to 60 millimeter of mercury is acceptable, but as long as your pH is maintained. If your pH is above 7.2, we tolerate a higher PCO2. Okay, and then however, this permissive hypercapnia, be mindful if you are ventilating in a child with head trauma or raised ICP, or a child who has pulmonary hypertension or severe cardiac dysfunction. You need we won't advise permissive hypercapnia. Then there's other strategy to reduce your barotrauma, that is permissive hypoxemia. If you remember that our target endpoint for saturation was not 90 or 94%, it is 88%. Okay, this is again a strategy to prevent your ventilator-induced lung injury. So we tolerate a lower PaO2 of 55 to 65 millimeter of mercury, provided your pH is maintained. Okay, again, this is all you should maintain now, pH of 7.2 at least. In severe ARDS, we tolerate a saturation as low as 80 to 90% in exchange for limiting your FiO2 to less than 60% and also minimizing PEEP requirement. Okay, so this is what we need to allow when you are ventilating, especially when you have like a difficult to ventilate child, a difficult like a severe ARDS. You need to give allow some space for permissive hypercapnia and permissive hypoxia. Then adjustment of the initiation. So your tidal volume, if you're using volume control or your PIP, if you're using pressure control, it should be sufficient enough to make the chest rise adequately. Okay, how do you check after intubation? Obviously, you do a chest X-ray, look for the tube positioning. You also check for air entry. If the air entry is bilaterally equal or not. Okay, look for the chest rise and look for your increasing saturation, increasing SpO2. You can do an ABG to see whether your hypoxia is getting corrected or not. And then these are other maneuvers to improve your oxygenation and ventilation, which will be talked about in the next lecture. Okay, then let's come to the supportive treatment. So that was your ventilation strategy, a mechanical, respiratory support and mechanical ventilation treatment. Now let's come to your supportive treatment. Okay, these are also equally important because again, this will determine how effective your ventilation is. All right. So first thing is you have to maintain adequate sedation and analgesia. You don't want any patient ventilator asynchrony. You want the patient to fight with the ventilation. All right. So you need to make sure that you're giving adequate sedation and analgesia. And moreover, it's going to be very painful. You don't want to put a tube down a child or a patient who is conscious. Okay, you can feel all that pain. So you need to make sure that you are giving adequate sedation and analgesia. Use an inline suction to avoid a loss of PEEP. Okay, use a HME, okay, or a humidifier to avoid formation of thick tenacious secretions. I think there were a lot of questions on this in the last class. So use an HME and a heated, that should be heated as well. Continue your cardiorespiratory monitoring. This again, we will talk in detail in the next session. Maintain your cardiac functions, use adequate fluids, use your inotropes judiciously, and don't ever forget nutritional support. Okay, we always give, we start rice tube feeding within 24 hours itself, unless there's any contraindication to feeding. But in that case, then you can use total parenteral nutrition. Again, know the what you call the pros and cons before starting your TPN. Then give for broad spectrum antibiotic coverage within 1 hour after you get the child, mainly because especially when you're dealing with sepsis and septic shock. Okay, you need to give antibiotics within 1 hour, and preferably, not preferably, it's advisable you always take a blood culture before you start any antibiotics. Okay, and then keep the patient relatively dry. Try to prevent fluid overload. Okay, because again, when you're giving too much fluid, again your lung will be overloaded with fluids. Okay, again, this will make your ventilation strategy very difficult as well. Then avoid frequent disconnection from your ventilators. Like I said, use inline suction. You can try prone positioning in hypoxemic child. Treat multi-organ dysfunctions if present. Again, that will indirectly affect your ARDS management as well. Prevent coagulopathy, shock. For stress ulcers, we use H1 antagonist, because this can cause bleeding as well because of the shock or other coagulopathy. And then always do a daily assessment and weaning. Once you put the child on ventilator, you need to assess, you need to monitor. So you need a good collaboration with your team, okay, your nursing team, the doctors, your MOs, your pediatrician. All of you have to be together. You have to work as a team for this, for treating a child with ARDS, for any child for that matter in PICU. And then there's something called transfusion trigger. Okay, so what we do is, if a child is having refractory hypoxemia or is in shock, okay, if your hemoglobin is less than 10, you need to transfuse it back RBC. Okay, so this is one thing that we have been practicing in most ICUs. They do the same thing. And then, but if your child is stable, hemodynamically stable, there's no shock, no inotropic support, the oxygenation is maintained with low ventilator setting, then we can tolerate a hemoglobin of 7 grams per deciliter. And also remember that multiple transfusion will again cause your ARDS. So you need to weigh those appropriately and see what transfusion you need. Okay, then we're coming towards the end of my talk. Okay, so the average mortality in ARDS. So for those of you who have managed ARDS, you know that the mortality is quite high, especially if you have a very difficult or severe ARDS patient, or the patient comes to you in like the late refractory, what you call decompensated stage. The mortality is very high. In adult, the mortality is as high as 35 to 46%. In children, because of the increased use of mechanical ventilation and all these like advanced ventilation strategies, does come lower to maybe 22 to 25%, and this trend has been decreasing over the last decade. There is one RCT that was done by endotracheal surfactant for pediatric acute lung injury. They said that if at entry the oxygenation index is more than equal to 13, the mortality is almost 40%. It's very high. You know, if the oxygenation index is less than equal to 12, the mortality is 20%. Okay, so if you have like lower, like if you can pick up this child before they turn to like a severe ARDS and act on it, you will also directly affect, increase your chance of survival and improve your prognosis. Okay. Again, one thing to remember is most patients, however, do not succumb. The cause of death because of respiratory failure per se is only 5%. Okay, because of the inadequate oxygenation, most of them succumb to that actually because of your multi-organ dysfunction, because of your shock, your liver damage, your renal kidney injury, and other injuries. Most of them succumb because of multi-organ dysfunctions. Again, be mindful and treat other multi-organ dysfunction as well. I think there was a series in AIMS that did that. They said that the mortality rate was 75. I don't know if this was true or not. Okay, in our hospital, we don't have the number for ARDS. I think we had, but I can't seem to find that. But in our hospital, we look at the survival of those whom we have ventilated. Okay, so it's almost 60%, 60 to 65%. So again, depending on which stage they come. Okay, so we don't have that detail, but then most of the patients that we have ventilated, around maybe 35 to 40% of them have expired. The rest we have a good survival of almost 65%. Okay, these are my references. Thank you. I think Dr. Saurabh has joined. No?
Yes.
I think welcome, Dr. Saurabh, sir. Nanuka will introduce you in a briefly.
I have not given access. Give me a second. Actually, I have not given access to unmute. Give me a second. I think, Saurabh sir,
Saurabh, sir, can you unmute?
So,
Yes, thank you. Thank you very much for you are there, Dr. Himesh is there.
Yes,
yes,
sir. Thank you so much for coming today, sir.
So, brief introduction just I wanted to give. Saurav sir was previously working as an assistant professor in Nigrin's hospital itself, but currently sir is working in Guwahati. So thank you once again for joining with us.
Thank you very much. I did not realize that we'll have so many participants.
Yes, sir. We have more than 500 participants.
I thought
Thank you,
maybe
sir.
around 50,
So now before
10,
taking up
yeah.
all your questions, I wanted to request Suresh sir to just put your input on regard to this topic. Thank you, sir.
Yeah, thank you. Good afternoon to all of you. The talk by Dr. Rosina is very nice, and it is very easy to understand, and she used a lot of pictures and diagrams which make us easier to understand. I think anyone can easily understand that presentation. She had given very practical examples, and the text or the material is very conceptual. She gave very evidence-based.
So I think sir's connection is not stable.
Yeah.
Yeah, am I audible?
Yes, sir. Yes, sir.
Yeah. So, and there are evidence-based guidelines that she had put in her presentation, and most importantly, she had given very clear messages and numbers and targets that we have to follow while managing a patient with ARDS. ARDS is one disease in sick children where we have clear numbers that we can follow. If we follow those numbers and target, we can easily. Am I audible? Hello?
Yes,
Yes,
sir.
yes, sir.
Yes,
Yes,
sir.
sir.
Yeah. So those numbers and targets are very important because
So go ahead, sir. Go ahead.
yeah, those numbers and targets are important because in ARDS, if we follow those numbers and stick to those numbers, then it is easier to manage a child and he may survive also. The other points which I want to highlight are the one is humidification during mechanical ventilation in any child, especially in children with ARDS. It is most often missed. So we have to
I
actively
think
look
again
whether.
we lost you, sir. Yes, sir.
Yeah, hello.
Yes, sir. Yes, sir. You are audible, sir.
Yeah. So humidification is very important in any mechanically ventilated patient. We have to check whether humidification is working or not. If our humidifier is not working, then we can use HME in between or continuously, and we can change that HME whenever it is soil dirty or maybe every 2 to 3 days. Fluid overload is another area which is often missed, and we don't actively look for fluid overload. So that has to be looked into, because if there is increase in fluid overload, then the mortality may increase itself. Other important point is adequate use of sedation, analgesia, and neuromuscular blocker is very important, because this is another area which is often ignored. And daily we have to assess whether we can wean this child or whether we can we can give a spontaneous breathing trial and assess for the weaning. So these are few additional comments that I want to give. Otherwise, the presentation is very good, and I had not attended any simple presentation than this, and it is very easy to understand. Thank you, Dr. Rosina.
Thank you so much, sir. Thank you so much, sir. Now, next, I would like to request Dr. Saurav Dhuhra, sir. Sir, can you please add some of the points from your point of view in this regard? Thank you, sir.
Thank you very much. This is the first presentation I have attended today, so I don't know what went on before today, how much you have delved into. But whatever, Dr. Rosina has given a very detailed presentation, as my co-moderator has said. And there is not much you can say. There is nothing much you can say except the other points of the. She has touched on almost all the points. What is important, however, is uh, in the setting that where you're working, what up to what limit you can go. Because I know this situation that in the Northeast we are less in resources, so probably rather than the diagnosis and when to ventilate, when to wean, these are very more important questions in our setting. And then up to what level you can go, and because we are resource limited, to be very frank. Thank you.
Okay. Thank you so much, sir. Thank you, sir.
Yes, thank you so much. And I have seen few of the questions in our chat box. So I just wanted to ask to Suresh sir, like, what is the best analgesia for a ventilated child?
Best analgesia and sedation. It's not only analgesia. We have to use both sedation as well as analgesia. So whatever you are more comfortable with, like we commonly use midazolam and morphine, or midazolam plus fentanyl. So in combination of benzodiazepine and opioids, and sometimes we do use dexmedetomidine. And in patients with ARDS, for initial 2 to 3 days of management, we often use neuromuscular blockers. So whatever sedation and analgesic drugs you are using and you are more comfortable, whatever they are easily available, and your unit is using them for quite long, are good enough to be used in this patient. But do use sedation and analgesia whenever you are ventilating a patient, whether it's ARDS or not ARDS. These are important intervention that has to be used. Regarding neuromuscular blockers, if the ARDS is very severe and you are having problem in ventilation, then I recommend to use neuromuscular blockers for initial maybe 48 or 72 hours.
Can you please mute? Yes, thank you. Yes, sir. Yes, sir.
So we lost you in between, sir, after neuromuscular block.
Yeah. Hello.
Yes, sir.
Yeah, regarding neuromuscular blocker, I just told that if ARDS is very severe and you are having some problem in ventilating and there is patient ventilator asynchrony. Hello, am I audible? Hello. Hello.
I think again, sir, we lost. Yes, sir.
Yeah. Hello, am I audible, madam?
Yes, sir. Yes, sir.
Yeah, regarding neuromuscular blocker, you can use neuromuscular blocker for initial 48 to 72 hours in patients with severe ARDS.
Thank you.
Thank you so much. Thank you. We actually have another dedicated session for sedation and analgesia. I think any other questions later on about that, we can cover it in that session. Thank you so much, Suresh, sir.
Thank you, ma'am.
Thank you, sir. And another question is, like, in some of the places in working days, can you please? One second. Can you please mute yourself, because I have given access so that you can ask the question. So sorry for disturbance. Sir, another question goes to Dr. Saurav, sir. Like, some of the places, they don't have a humidifier. So they are asking whether HME filter only sufficient for that.
Yes. In pediatric patients, HME is sufficient because in most of the places we.
Again, I think.
Hello.
Yes, sir. Yes, sir.
Yeah. Yes, it is sufficient, but the only thing, as my Dr. Suresh has said, the important point is that we have to remove it once it is soiled. That is very, very important. Otherwise the CO2 will go on building. That's very important. Otherwise we can continue using HME in place of humidifier. And while using humidifier also has its own set of problems, like we have problems with infections, problem with whether we see that the proper available sterile water is available or not. These problems are there. Okay.
Yes, sir. And then one more question is there, like any specific neuromuscular blocker you choose? Suresh, sir, you want to answer these questions?
Yeah, nothing specific about neuromuscular blocker, but we often use neuromuscular blockers like vicuronium or atracurium. and we don't use other neuromuscular blockers. These are the two which we commonly use.
Yeah, thank you, sir.
Thank you,
One,
sir.
just I would
And
like to
again,
add on.
MTM ma'am has mentioned like it is advisable to provide a prone positions to an infant with uncuffed endotracheal tube under a mechanical ventilation. Ma'am, thank you for your comment.
Just
So,
one point I would like to add here
yes, sir.
is that whatever you're using, you should be comfortable with whatever agent you're using, sedative analgesia, or
Yeah.
that you should be
Yes,
comfortable
sir.
that you're using it for a long time.
Sir, again, we lost you.
Okay. So what I was saying is that whatever agent you're using is for sedation, analgesia, you should be using it. You should be comfortable with it, that you have been using it for a long time.
Yes, sir.
That
Yes,
is
sir.
important. Yeah.
Okay, thank you, sir. Thank you, sir. I think hope you got your answer. And then another question is like, what are the amount of fluid that can be safe to give?
Hello.
Saurav sir, Suresh sir, anyone
Yeah,
who
yeah.
would like
Yes, yes,
to?
yes.
Thank
So
you.
amount of fluid, there is no clear-cut answer, but the volume with which you are able to maintain adequate intravascular volume, adequate hemodynamics, uh, the tissue perfusion is okay, your oxygen carrying capacity is good. So that amount of water is okay. So if you ask me in percentage, so in any ventilated patient, any volume from 40% to 70% of the normal maintenance fluid.
Suresh sir, yes.
Yeah, hello.
Yes, sir.
So if you want to listen to numbers, then maybe any fluid from 40% to 70% of the normal maintenance fluid that we calculate by using Holiday Sagar formula, you can use that to maintain adequate hemodynamics, like blood pressure, heart rate, urine output, and blood sugar. So though, and we should use as
Thank you, sir. Even
liters.
we do that. We keep like about 2/3 of
Yeah.
the total fluid requirement, including your inotropes, your feeds,
Yeah,
and
yeah,
your drugs and all that, and
yeah,
even lesser if required. So I
yeah,
think that's a
yeah.
good answer.
Yeah, that's right. Yeah, and we have to take care of all other fluids, that infusions, blood products, boluses. We have to take care of all those things, that those should be counted in the maintenance fluid.
Yes, sir. I think again we lost you, sir. Yes, sir. Uh,
I think, sorry, there must be some internet issues. So I wanted to, tell you that we have to take into account the extra fluids we used to give in form of infusions, in form of blood products. So all those things we have to deduct from the amount of fluid that we wanted to give for next 24 hours.
Yes, sir. They should also be included in the total 24-hour fluid requirement, no?
Yeah,
That we
yes.
don't cause fluid overload.
Yeah, that's true.
Thank you, sir.
Thank you, sir. And one more last question is like, do we have a different size HME for a different age group? Saurav sir, you want to answer this one? Like,
Yes, we have different size for infant and pediatric and adult. We have to use it according to the age group. So different sizes for that.
An adult, no?
yeah. Okay, I think sort of answer like we have a different size of HME. Thank you, sir. And now I have not seen any more queries in our chat box. If any participant want to ask any queries, you are please feel free to ask. Otherwise, again, we are going to proceed with our next topic. Anyone wanted to ask any question, please unmute yourself and you can ask. Okay. So next topic, and we have next topic will be presented by Dr. Himesh Varman, sir. Sir is in topic titrating ventilator setting. So now I think I have not seen any more questions. Now straightforward, we are going for the next presentations. And I would like to request Saurav sir and Suresh sir to stay behind. So again, after these sessions, might be there will be open discussions for this topic. So without much delay, I would like to hand over this forum to Dr. Himesh Varman, sir. Over to you, sir. Thank you.
Okay, so I could just make it slideshow. So good afternoon, everybody, and special thanks to Dr. Suresh and Dr. Saurav for agreeing to be part of this. And Dr. Suresh, your presence is a great value addition to this people and then to this workshop. And then all our participants are hugely benefited from your wisdom. And Dr. Saurav, he was one of the faculty member at NIGRIMS, and he was the one who has actually nurtures this ICU for quite some time before he had to leave for his personal reasons. So it's a pleasure having you back, Dr. Saurav. So in next 30 minutes or so, I'll try to take you through some illustrative case scenarios, trying to drive some of the important concepts of titrating these settings of ventilator. Now, these are not real cases. These are illustrative cases, and it's for the purpose of making you understand the concept. And I hope I will be able to do that. Yeah. So, outline of my talk, we will talk about some strategies to correct hypoxemia, strategies to correct hypoventilation and hypercarbia. Then some illustrative cases on troubleshooting acute desaturation, and illustrative cases on discussion on titrating settings in face of hypoxemia and hypercarbia. So titrating settings, actually, Rosina was also mentioning a couple of minutes back. It's based on some acceptable targets, and these need not be necessarily normal values. So we are not looking at a cosmetically normal values in our blood gases or in a saturation, but certain targets which are acceptable. And every patient is different, so it depends on the lung mechanics. It depends on the presence of shock or other comorbidities, the pH, acid-base status of the child. So it depends on so many factors. So it is basically keeping this principle in mind. It's a trial and error based and individualization to each patient. And while doing so, we will have to keep in mind the safe limits of the ventilator parameters that we will be setting. So some acceptable targets include, we want to keep PO2 somewhere around 80 millimeter of mercury, keep SpO2 more than around 92 percentage, but in difficult situation, as Rosina was saying, that you can tolerate even lower, like 88, but if you're coming below that, you need to be more dependent on your to measure PaO2. But as long as it's more than 92, you're relatively safe. You are not, because we understand that most of you are not running a full-fledged ICU as of now, and your access to blood gas also may not be that great. So it may be better to keep a saturation on higher side. And if you're tolerating a lower saturation, make sure that you do a arterial blood gas. In difficult to ventilate situations like ARDS and all, you can tolerate a hypoxemia up to 50 mm of mercury, which is also called as permissive hypoxemia, but this is only for such cases. But normally you want to keep it a bit higher. PCO2, you want to target a normal range, but would like to keep it on a higher side of the normal range. And then in difficult situation, again, you can tolerate up to 60 mm of mercury, and provided you can keep the pH above 7.2, which is also called permissive hypercarbia. Now, safer limits of variable are like PIP, you should not go beyond 30. PEEP in restrictive lung diseases, you can slowly, based on the condition of the lung, you can titrate up, and you usually start from 6, and then based on what you require, you may go up to 10. Usually in very severe cases, you may have slightly higher than that also, but these are, I'm just giving, these are indicative numbers. These are not like that you have to follow these numbers. These are indicative number, what kind of numbers may be required. In obstructive lung diseases, you like asthma, you want to keep a lower PEEP at around 2 to 3 centimeter of water. And respiratory rates, while setting, it has to be closest possible to the physiological rate of the child. Eye time in older children, you would want to keep not less than 0.4, and you may need longer eye time in bad lung, whether it's a restrictive lung disease or obstructive lung disease, because the inspiratory time constant in such situation is longer. So you need longer time to deliver a certain amount of tidal volume. And IE ratio, normally you want to start at around normal lung, you will want to keep it around 1:2 to 1:3. And in restrictive lung diseases like pneumonia, ARDS, you want to keep it 1:1.5 to 2, or sometimes you have to tolerate even lower, like 1:1, or you even have to go to reverse IE sometimes. And in obstructive disease, on the contrary, you have to give a longer IE ratio is to 1:4 or 1:5. So for titrating hypoxemia, ventilator settings for hypoxemia and hypercarbia. For hypoxemia, first we can see, like for hypoxemia, a knee-jerk response is to increase the FiO2. That looks like an obvious choice. So you first need to assess the situation as a whole and decide what is causing the hypoxemia. Now, if there is a scope to increase hypoxemia, FiO2, then you may increase FiO2. If FiO2 is in a, if there is no scope or it's going to an unsafe range, then you have to touch the mean airway pressure. So to increase the mean airway pressure, your options are increasing PEEP, increasing the I time, which will increase the IE ratio. And some situations you can need to increase PIP, that will also result in increase in mean airway pressure and increase of respiratory rate without decreasing the I time. So this later two strategy will also result in increase in tidal volume and maybe useful in troubleshooting situations where there is hypoxemia with some hypercarbia as well. If there is only hypercarbia, then our main target is to look at the minute ventilation, and to increase for increasing the minute ventilation, you want to increase the respiratory rate and the tidal volume. So these two things can be touched for that. So if you are doing a volume control, you can touch the VT, or if you are on pressure control, you have to increase the delta P, that will and VT will be a as a result of increase of the delta P. Let's start with a scenario here. This is a 9-year-old boy who had head injury following fall from height and who has a normal lung and is on ventilator. So the setting is given on the right side of your screen. Now he has returned from the CT scan room. He has gone to CT scan and he's come back from the CT scan room. He's shifted from the trolley to the bed and is connected back on the ventilator on the same ventilator setting. Okay. So he was initially maintaining, but before you could leave from the bedside and he is positioned properly, he starts desaturating quickly. So his initial saturation was 99, falls to 92, 88, 80, and 70. So it started desaturating quickly. What would you do? You may not put it in chat box, but take 2-3 seconds to just think about it. What would you do in this scenario? Which are the ventilator parameters you are going to touch, or are you going to do something else? Now, in this situation, what we need to think is we don't need to touch the ventilator setting. If there is an acute saturation, then you need to think about a mnemonic called DOPE, D-O-P-E. So this would mean D for displacement, O for obstruction, P for pneumothorax, and E for equipment failure. So what would you do in this particular child who has quickly started desaturating? We'll take the child there is a chest rise or not. So in displacement, there will be no chest rise, but bagging will not feel stiff. Okay, so the bagging doesn't feel stiff, and no chest rise is also there, and child is not improving. So these could mean there is the tube has got displaced. But if you have capnography in your settings, and you can also use capnography to confirm whether the tube is in place or not. Next scenario could be, there could be obstruction. So in obstruction, again, when you start bagging with the bag and mask, there is no chest rise, but the bag will feel very stiff because there is obstruction and the child will not improve. Again, third scenario could be pneumothorax. So again, when you are bagging the child with if there is pneumothorax. So this could be variable depending on what is the degree of pneumothorax. So there could be either if no chest rise, or there could be an asymmetrical chest rise, or sometimes there could be a lower than normal or even normal chest rise could be there. But the bag would feel a bit stiff because the pneumothorax will cause compliance of the whole lung and chest wall unit to go down. So in these situation, you need to do a diagnostic tap to confirm that this pneumothorax. Mind you that you will not have enough time to ask for a X-ray to come all over and do the X-ray and then get the film back to your place. So if you are suspecting pneumothorax in a ventilator type setting, in a PICU setting, then without waiting for the X-ray, and if there is an acute desaturation, then you must do a diagnostic tap to rule out pneumothorax. Now, fourth scenario could be an equipment failure. So in equipment failure, when you take the child on bag and bag ventilation, then you will see a good chest rise, and then bag will not feel stiff. And the child quickly starts recovering. So this means that there is something wrong with the ventilator, and you need to either correct that, identify that and correct that, or you can just change the ventilator and take another ventilator that you may have kept standby in your unit, right? So the point here is that if there is an acute desaturation, then do not try to touch ventilator settings and try to increase the ventilator settings there. Think of dope and troubleshoot it. Whether the tube has got displaced, whether there is an obstruction in the tube, whether there is a pneumothorax, or if the equipment has failed, your ventilator has malfunctioned. Okay. Now, suppose in this child, the tube got displaced. Okay, so you troubleshoot that and you found that the tube is displaced, and then it was quickly diagnosed. The tube was removed. The child was pre-oxygenated with bag and mask, and then re-intubated again. Okay, and then connected back to the ventilator with same ventilatory settings. Okay, but now immediately post intubation, you confirm the position. You have asked for a chest X-ray that will come. In the meantime, the saturation is around 88% on ventilator once you have collected in the ventilator settings that is shown on the right side of the screen. So what would you do now? Now, if you see one by one, the ventilator VT is more or less normal. FiO2 is very acceptable. Then PEEP, which is a normal lung, we don't need more than that. So other settings are normal. So in this situation, we can very easily increase the FiO2. So we can increase the FiO2 to 35%, and then that will probably take care of these situation. And then we take a blood gas after 30 minutes, and the X-ray will also come back in the meantime. So we can take a decision based on that. So in this kind of situation, for hypoxemia, we have decided to increase the FiO2. Okay. Now, another scenario, a 2-year-old child, severe pneumonia, ideal body weight 12 kg, is on day 2 of PICU stay. Your saturations are 88%. This is the blood gas. So you have a pH of 7.42, PA2 of 60, PCO2 of 42, and bicarb of 24. So what would you do? And these are the ventilatory settings. So you have a PIP of 20, VT of 70 to 80, so that's acceptable as per the body weight. FiO2 of 70, that's high, right? Then PEEP of 5 and respiratory rate of 30, PI of 0.6. Yeah. Okay. So increase FiO2. So in first scenario, we increase FiO2. So in this situation, we'll see that we cannot touch the FiO2 further at this moment because FiO2 is already very high, and here it's in day 2 of PICU stay. So the child is already on FiO2 of 70% for more than probably 24 hours. So touching the FiO2 would be one of the later options if we are pushed against the wall. So we need to look at other parameters. So again, this is an hypoxemia. So because it's an hypoxemia, that means we would not want to increase VT, and VT is almost in an acceptable range now. So we can decide of either touching we have to decide on touching the mean airway pressure, as I was discussing earlier. So for mean airway pressure, we can either increase the PEEP or alter the IE ratio, right? So here IE ratio is 1:2.1. So what we can do here is that we can make these kind of changes, and we increase the PWP to 7. Then we increase the I time to decrease the IE ratio to 1:1.5. Okay, and VT may remain normal, same, or sometimes it may decrease because we have increased the PEEP without touching the PIP. So that means the delta P will come down and the VT may slightly decrease. If the child was in a de-recruited state, in fact, there could be increase in compliance and there could be increase in the tidal volume also. So that depends again on case-to-case basis. But this is an again illustrative case. So I'm trying to show that with increasing of PEEP and in optimizing of the I time and IE ratio, we may be able to correct the hypoxemia. At the same time, we may be able to bring down the FiO2 to safer limits, right? So in all cases of hypoxemia, your knee-jerk response should not be to increase the FiO2 on the ventilator, right? So that's the message goes from this case. Now, scenario 3, this is a 3-year-old with meningoencephalitis, is just intubated and connected to the mechanical ventilator. Now, as these are the ventilator settings, PIP 18, VT is because it's on a pressure control mode, the VT is fluctuating between 130 to 150, FiO2 50%, PEEP of 5, respiratory rate 20, okay, and you have an IE ratio of 1:2.8, okay. On these settings, you have this. Sorry, yes, this SpO2 is written mistakenly. The SpO2 is like 100%. Okay, the SpO2 is 100%. pH is 7.42. PaO2 is 200. PCO2 55, and bicarb is 24. So in this setting, what would you do? Please put in the chat box your responses. Okay, so first we need to decide what are our problems. Do we have a problem with hypoxemia or do we have a problem with ventilation, right? So here our problems are oxygenation is good. In fact, it's too good for the child. Even though our FiO2 is normal, we do not need so much of oxygenation. So we do not have an oxygenation problem, but PCO2 is 55, okay? So PCO2 55 and this child is having meningoencephalitis. So there is a raised intracranial tension type of situation where we do not tolerate this high PCO2. So we for our tolerance, PCO2 is too high given the clinical scenario in this case. So what would we do here? So we need to look for situations which will troubleshoot the increase in PCO2, or we have to increase the ventilation of this child, not the parameters that would increase oxygenation. Okay, so okay, correct. So there are a lot of responses telling a lot of things. One thing, before we go to what we'll see what we do in this case, but before going there, do not touch too many buttons on the ventilator at one go. First decide which one to do, and then you touch one by one in an incremental manner, and do not make too many changes in the ventilator in very quick succession. Okay, why it's not going forward? Okay, so what we do here, what we could do here is that FiO2 was 50, so a PaO2 of 200 is too high, so we could bring down the FiO2 to 30%. Then PEEP is fine. If we need to increase the minute ventilation, we had an option between increasing the VT or increasing the respiratory rate. But here for a 15 kg child, we are almost ventilating at around 10 ml per kg. So we don't want to increase the VT any further, right? So therefore we would decide not to increase the VT, and to increase the minute ventilation, we will increase the respiratory rate in this case, right? So is it clear? So we had to increase the ventilation. For ventilation, we need to increase the minute ventilation. For minute ventilation, we have two things, tidal volume and respiratory rate. So in this child, tidal volume was already optimized. So we will try to increase the respiratory rate so to achieve a higher tidal, higher minute ventilation, right? So you can do it and titrate it with your ABG, or to make the changes, you can also, how much rate increase should be there, you can use this formula. For a desired rate, you can take this current respiratory rate into current carbon dioxide divided by desired carbon dioxide. So you can use this formula to get an idea about how much increase or decrease of respiratory rates needs to be done in a child where you are trying to increase or decrease rates and achieve a desired PCO2. Now, again for PCO2, this is regarding the minute ventilation. Another aspects of minute increasing PCO2 is the equipment dead space. Okay, so in equipment dead space, you have like anything that is connected beyond the Y connector of the ventilator could be an equipment dead space. This could be all connectors, HME that is joined, the endotracheal tube, if it is too long. So these could be a part of, you need to look into that as this could be the cause of hypercarbia. Okay? And if you have capnograph in your setting, then you can have something like this. What you are seeing here is that the capnography is not touching the baseline. So this means there is rebreathing, and this rebreathing usually means that there is an increased dead space, equipment dead space. So you need to correct it. And if you do not have a capnograph, you can have a trial and error, and you can, if you can optimize your setting and then see if there is any equipment dead space, it is possible to decrease that. So say if your endotracheal tube was left too long, so can you cut that short? Can you shorten the connector that is between the Y connector and the ET tube? So you could just explore those options, and in your case, if it is possible, you can just try that and then maybe repeat the blood gas and see whether your PCO2 comes into control, right? So for ventilation, rise in PCO2, you would look at the minute ventilation and troubleshoot that, and you would look for equipment dead space and troubleshoot that. Now, again, scenario 4, here, this 8-year-old boy with severe pneumonia on ventilator, SpO2 98%, but this child is gasping on ventilator. Okay, so you have put the child on ventilator, but the child is having a gasping type of breathing on the ventilator. So if you look at the setting here, PIP of 16, VT is good. It's almost like 10 to 12 ml per kg it's going. FiO2 requirement is 70%, PEEP 5, respiratory rate 25, I time 0.8, and I is to E is 1:2. So what would you do? What kind of changes would you want to make in this ventilator setting? Yes, please put your responses in chat box. Okay, so here primary problem here is that we do not want a patient, if a patient is gasping on ventilator, something is not right? So that's the core point. I'm just giving you a hint, and think about making ventilator settings, thinking that as a problem. Correct. So here the problem is, if I have been telling you that PIP is one, that is delta P causes the results in the VT, right? So if in this case you may be tempted to decrease the PIP further because the tidal volume is high, right? And it's a restrictive lung disease, it's a severe pneumonia, so you don't want a tidal volume of 12 to be there. So you may be tempted to decrease the PIP in this situation. But remember that these PIP is not delivered. It's 16 of delta P of around 11 is very low for a severe pneumonia. So to give that kind of tidal volume, this is because the patient is generating his own effort, and that is drawing that tidal volume, right? So don't get misled by that. And so there is a very disconnect between the settings. You have a quite low PEEP with low PIP, but you have a very high FiO2. So this ventilator setting is definitely not correct. If you look at the ABG, then you have a pH of 7.4, PaO2 of 125, PCO2 of 32, bicarb of 18. So here also the carbon dioxide washout is happening because the tidal volume is okay. You have given enough oxygen, so PaO2 is also looks normal. So you may think that, okay, this is good enough ventilator setting, why touch it, anything, right? But you will not want to tolerate this type of breathing. This child will tire out. This child is fighting with the ventilator at this moment, and then quickly will tire out. So what we need to do, as rightly pointed out by many of you in chat box, so we need to increase the support of this. Okay. So say suppose we increase the PIP to somewhere around slowly, we have to titrate it, and slowly we can increase it to up to 22. Maybe the PEEP can be titrated up, say to up to around 9. So the principles of titration, Dr. Rosina has already told you. So based on that, you can make these changes. So this child was having an inadequate ventilator support. So be aware of these situations also. Only looking at the ventilator and blood gas is not enough. Look at the patient, and if such problem is there, you need to troubleshoot that. If you have a ventilator that needs you to set the flow separately, in that case, this could be also a flow starvation. So you may need to increase the flow in those situations, but most ventilator need not have flow need not be set separately. So in this situation, setting these parameter would be enough. So take home message, this is my last slide. So titration will require you to keep a lot of factors in mind. These include like the primary disease. We saw that the meningoencephalitis, we did not tolerate the PCO2 of 55. So the primary disease also needs to be kept in mind. Then lung mechanics, based on the different lung will behave differently, and what is safe, what is unsafe for which lung, we have to decide on that. Then we have to keep the acceptable blood gas targets in our mind, and not the normal blood gas targets. And the safety ceiling of the parameters must be kept in mind. So every child will be different, and setting will be highly individualized at bedside, keeping these principles in mind. So my purpose was to just make you understand the principles, so that based on which you can titrate the setting at bedside in your children, right? So that is all. That is all from my side, I think.
Thank you so much, sir, for the wonderful session. Now, I would like to request Suresh, sir, to add your point of view on this topic, sir.
Yeah, thank you, Dr. Himesh. The presentation was very nice, and your 4 troubleshooting clinical scenarios covered almost everything that we encounter in a day-to-day mechanical ventilation, and especially in children with ARDS. Those are very wonderful scenarios that you had covered. I must congratulate you. There's nothing from my side to be added to this presentation. I think we can take the questions if there are any in the chat box.
Okay. Dr. Saurav, sir, you want to add anything?
No, otherwise it's Dr. Himesh has covered it very comprehensively. Only thing is that I wanted to say is that because our task as pediatricians is double that of adults, because whatever in all, every child is different. We deal with different weights, different age groups. So as Dr. Himesh has said, we have to individualize every patient. That's all. Thank you.
Thank you, sir. Thank you, sir. And there is a few questions like asked by some of the participants, like what is the base flow in a ventilator? Dr. Suresh, sir, you want to answer this one?
Yeah, base flow is base or bias flow is the flow of gas which keeps on flowing through the circuit or through the mechanically parts of the mechanical ventilator, which generate the tidal volume, and we can adjust the pressures pressures can be adjusted by the software in the ventilator, but in some ventilators this bias flow is fixed, but in few ventilators we can adjust the bias flow if we know that patient is having flow starvation. So it is the amount of flow which keeps rolling inside the circuit. So that is what bias flow is.
Okay, thank you, sir. I think I have not seen any more questions.
Dr. Suresh, I have one question. I'll just take this opportunity to learn something from you during this. So first thing is regarding this flow, we don't need to set anything separately, right? Based on the your PI hour settings and the flow wave pattern. So the ventilator will decide on the flow, or do we need to set it?
See, flow pattern is different in pressure control ventilation and volume control ventilation. So we can, in some of the ventilators, we can set the pattern of the flow, like whether you want flow acceleration, flow deceleration, or like there are different forms of flow pattern which we can set, but we can't increase or decrease the volume of flow or the amount of flow in ventilators that we are now getting these days, but we can change the pattern of the flow.
Correct. So most of our participants need not bother about flow for practical reasons, right, Dr. Suresh?
Yeah, yes,
correct.
Yes,
That's yeah. And one more thing, Dr. Suresh, I want to learn from you is how do you this individualize trigger? What kind of numbers would you set for triggers, and how do you manage that?
Yeah, there are two types of triggers that are commonly available in ventilators. Like one is flow trigger, and second one is pressure trigger. We feel that the flow trigger is better, and if we set a patient on flow trigger, then patient has to make very less effort to trigger a breath as compared to pressure trigger. So we are more comfortable with the flow trigger, and we set it depending on the age of the patient. So if a child is younger, then a low flow trigger, and if a child is a bit older, we can set high flow trigger. The commonly set flow is 1 to 2 liter per minute. If we feel that child is triggering excessively, then we can increase the flow up to 4 or 5 liters per minute, so that the ventilator patient asynchrony can be avoided.
Okay. So do you decide on any ratio of the your tidal volume based on size of the child, or how do you set? It's just empirically 1 to 2 liters?
Tidal volume or flow trigger?
Oh, flow trigger, yes.
No, we don't titrate the flow trigger based on the tidal volume. We just set based on the lower number for the younger children and higher number for the larger children.
Okay. Thank you, Dr. Suresh.
So, I think one question is also asked, like,
Can I?
Yes,
I just wanted to know
sir.
from Dr. Himesh.
Yes.
What is the condition? What kind of cases are you getting nowadays? Because when we were there at the time, we used to get a lot of pneumonias, ARDS. Is it the condition is same, or is it better nowadays? Means regarding infectious disease and all.
It's almost similar, but maybe 90% of what you left means it's slightly better, maybe, but not so much. It's almost we're getting the same profile of cases.
Okay.
Thank you, sir. I think one question. You want to ask me? Yes, yes.
I have a question for you. In your hospital,
Hello, yes, ma'am. Yeah.
so in your hospital, which setting do you normally prefer for managing patient with ARDS?
We commonly use pressure control mode of ventilation, PCSIMV with the pressure support ventilation. We don't use volume control mode of ventilation commonly. We are more comfortable with pressure control mode of ventilation.
All right.
Are there any situations where in your unit you would use volume control, Dr. Suresh?
Even ARDS patient, we ventilate on pressure control mode of ventilation. But if we want a specific targeted tidal volume to be delivered, then we often paralyze the patient and use volume control. But that situation is very uncommon, not a common practice in our unit.
Okay. And in older children with normal lung type of situation, also you would use pressure or volume in such situations?
Yeah, we use pressure control ventilation.
Pressure only.
Thank you, sir. PRVC, no? Advanced one. Is that again? Does that depend on your comfort level between like PSIMV mode or PRVC?
Yeah. Yes. Yeah.
Oh,
True.
okay, sir. Thank you, sir.
Because whatever mode you use, it doesn't make any difference. I mean, studies have shown that both the modes are equally effective. So with whatever mode you are more comfortable, you can use that.
Yes, sir. Thank you, sir.
Thank you, Suresh, sir. A few questions are also there in chat box, like in case of CNS with a tachypnea, low PaO2, what pressure trigger we should set? This question is asked by Dr. Desa. Saurabh sir, Suresh sir, you want to answer this one?
Dr. Suresh has already answered this, I think. So you would set at 1 to 2 liters per minute. That would be the flow trigger you would use, and that is the number that Dr. Suresh has already told, right, Dr. Suresh?
Yeah, yes, that's true. Sir.
Thank you, sir. And another question is like how to decrease the death space in the equipment. That's already covered. You have already covered. You want to answer?
Yeah.
How to decrease this dead space?
Yeah, Dr. Suresh, maybe I just want to respond on this. Maybe you can give your take. How do you manage equipment dead space?
We can't do much about the size of the circuit, whatever is available in the commercially available, or we do have reusable circuits in our unit. We can't do much about that. But try in reusable circuit, what we can do is we can avoid we can use minimal connections. Like sometime what happen is expiratory limb is having two limbs which can be connected to the water trap. We can use only one limb, and try to avoid very long mouthpieces which connect between the Y piece and the endotracheal tube end. And if you are using HME, that it should be appropriate for the size of the child, not too big HME for that. So these are the only things which we can use, and we can also reduce the size of ET, which like ET size should be as short as possible. It's not too long. ET should not be too long.
Share this. So, this is what Dr. Suresh was mentioning about. This is the please please mute your. This is what Dr. Suresh was mentioning about. So this is the Y connector of the ventilator where the tubes comes and goes. From here, you can use some connectors to the endotracheal tube, and you can try to decrease this connector to decrease the equipment dead space, and make sure that you are using a corresponding amount of your the HME should be of the corresponding tidal volume. So that comes as for lower tidal volumes, you will have a smaller HME, and for higher tidal volumes, you have a bigger HME. And then the endotracheal tube, as Dr. Suresh was making a mention, that if your dead space is becoming a problem, you need to optimize and cut it short, but around 3 to 4 inches from the tip, from the lip, that can be.
Yeah, I have seen somewhere one questions like one question is like it's mentioned here, like can we detect the ET obstructions with a graph and figure in the ventilator? Saurav sir, Dr. Saurav sir, are you there? Yeah. Okay.
Yes, yes, I am there.
Yes, yes, sir. So
Yes,
one question is.
Yes, we do. We can predict ET obstruction with graph in a ventilator. What happens is that one important point is that suppose we have a lot of water in the circuit, then the graph that we're going to see is going to be a kind of it will not be in a straight line. It will be a shaggy kind of line. That is one thing. And second important thing, the graph that we're going to see is going to be restrictive pattern graph. It's not going to flow properly. I think these are very important. Of course, that will be a very different topic altogether. I think Dr. Suresh can add on to it.
Thank you, sir. And I have seen a hand raise from a new star, sir. Yes. A new star can, sir, can you please unmute yourself and you can ask? Actually, he have asked these questions for Dr. Suresh. Like, if you have a capnography, you use mainstream or side stream?
Yeah, okay. Yeah, thank you, ma'am. Thanks. The mainstream capnograph is, we have both kind of capnograph, mainstream and side stream. Mainstream, I feel they are better, because with side stream, what happens is there is some amount of air is sucked from the circuit, and the tubing of the side stream capnograph, it frequently get clogged with the secretions and whatever water is there in the form of humidification. So I don't find that side stream capnograph is very good. I prefer if we have both available, then mainstream is good.
Okay. So one
Though,
more.
though it has some some volume of dead space, but I don't think that's too much of dead space in it.
Yeah. So all of you, anybody, if you are planning to buy capnography, please buy main strip. Don't go for side strip.
And we have
Okay.
also asked another
Yeah.
question. Yes, you can unmute yourself. Thank you.
Yeah. Thank you very much, sir, for that for answering that question. Am I audible?
Yes,
Yes.
yes. You
Yeah.
are audible.
So I'm actually basically an anesthetist, so I usually manage adults patient. Like, of course, I'm out of critical care now for almost 2 years. So I was very much curious about managing pediatric patients because of course, we do manage pediatric patient like in the operative theater. That is for a short, brief period of time. But when you talk about overall management of a pediatric patient, I believe it is a very complex process altogether, like what Dr. Saurav was already mentioning, because different age groups in the pediatric age group itself, different age groups, they behave differently. So actually, my question was I wanted to actually most of the things you had already Dr. Sir Himesh has already asked also, and in between regarding the trigger values, because most of the values we are familiar. I mean, I'm familiar is with adult values which we are talking about. But when you talk about pediatric age group, it's totally different, and it's not just one value. It'll be different value for different age groups, perhaps. And one thing is, we as in adults, we prefer mostly volume control ventilation, but the traditional teaching has been that in pediatric age group we prefer mostly pressure control ventilation. So my question is actually pressure control ventilation you would be using for which, I mean, up to what age group? What I have I mean, what I usually, I mean, in my experience is I usually switch to pressure control ventilation only when my volume control ventilation touches very high pressure. I mean, like for the targeted tidal volume, if my pressure limits are going very high, so I try to switch over to pressure control. So I'm able to achieve the same tidal volume for at much lower pressure targets. So that is what I do in adults. But in pediatric, mostly I've seen they are using pressure control ventilation. So you prefer to do that, sir, even in neonates, and even in infants, and then child and older child, do you do that, sir? And of course, like even those limits which we talked about, I think the last session we had talked about flow. So I had got some information on that as well, because in adults we use about 40 to 60 liters flow, but in probably in child we use about 4 times the minute ventilation, so I had mentioned last time. And then even trigger also, trigger usually we use at around 3 to 5 liters in adults, but I'm not very sure about in children, different age group, like in neonates, what would be the trigger. And then I mean, like as the age and the weight increases, or would there be different triggers? So Dr. Suresh had clarified earlier that we use around 2 to 3 liters flow, so that would probably be the same for all age group, sir.
Yep, I'll try to attempt to address this thing before I pass on this same to Dr. Suresh for further comments. First is about your triggers, right? That for triggers, it could be 1 to 2, and as I said, it's small, younger child, you will have a lower trigger, and older child, you will use a higher trigger. But be mindful of, sometimes if you come too low, then there could be some auto triggering. So if your child is not triggering, but the ventilator circuit is triggering, so that you need to look into it. Sometimes what happens, there could if you are using a humidifier and not HME, there could be some fluid that is there in the your expiration limb, and this fluid could be oscillating, and these oscillation can cause that changes in fluid, and that also can auto trigger. So these are some challenges that when you are ventilating younger kids, and when we're setting the trigger. So based on that, but more or less 1 to 2 you can keep for younger children, and then for older you can go higher. So that is one. Regarding next question was regarding volume control and pressure control. I think as Dr. Saurav had made a point that you should use things that you are comfortable with. So if you are comfortable with volume control, at least in older children, I don't know there is any specific age, because I'm aware in many of the CTVS centers in USA and all, they would, even younger kids, they would ventilate on volume control. So it depends on the expertise and the comfort level of the team that is treating that. But you're, again, keeping the conditions or the principles of your safety and that in mind. So I think there is no exact cutoff, but more or less, if you are your leak is more, again, volume control will not work. Like if you are on a young child without without a cuffed endotracheal tube. A non-cuffed endotracheal tube, your volume control would be probably difficult. So you can, older children, cuff tube, you can still continue to use volume control if you are comfortable with that mode. And then only in very young children, or if there are things, you can switch over to pressure control. Dr. Suresh, what are your thoughts?
Sir, Dr. Himesh, nothing more to add. Yeah, you have rightly pointed those, cleared those doubts.
Sir, and one more question I would like to add. Like as far as endotracheal tube are concerned, nowadays, like in the operating theater situation, we are also using a cuffed tube even in
I think sir, your voice is breaking.
time in the eye setting.
Sir, I think we lost you.
I think if I may just, if I understood Dr. Newster correctly, Dr. Suresh, Dr. Newster was trying to understand that would you prefer a cuff tube in all ages, or is there anything to choose between would you choose cuffed versus non-cuffed, and anything on that?
Yeah. So if we have cuff tubes are available, then I prefer cuff tubes if all sizes are there. But usually cuff tubes less than 3.5s, they are not available in all centers, and even in few centers, tubes below 5.5 with cuff, they are not available. But if given chance, cuff tubes are available, then I would prefer to use cuff tubes, especially if I am ventilating a patient with ARDS.
Okay.
Thank
Thank you, sir.
And
Anything else?
I have seen the hand raised by Albina ma'am. If you want to ask anything, I have seen hand raised since a long time. Albina ma'am? Albina ma'am, you want to ask anything? By the time sir, Newster sir have again asked another question. Okay. I think I have not seen any more questions. Yes. I think I have not, yes, I have not seen any more questions in our chat box. If any participants want to ask, please unmute yourself and then you can ask. Feel free to ask. Okay, yes. I think we are ahead of our time also. So I think we will end our sessions. I have shared pretest and feedback link in our chat box. Chat box. So I would like to thank Suresh sir and
Thank you, ma'am.
Saurav sir for adding your valuable thoughts in our topic and also clarifying doubts of our participants. So we would like to thank you on behalf of all the participants. I also like to thank Himesh sir and the Rosina ma'am for the wonderful sessions. Thank you so much, Dr. Suresh.
Thank you, ma'am. Thank you. Thanks, Dr. Rosina, Dr. Himesh, and Dr. Saurav. And
Thank you.
we had a very nice discussion. Thank you.
Thank you very much.
Yes.
And thank you to all the participants for staying, being so enthusiastic and still till such late time, till the end.
Yes.
Thank you.
Thank you. Thanks.
Thank you.
Thank you, ma'am.